This module introduces the need and in many specific ways attempts to demonstrate the continuum of care we can provide as part of care, treatment and support initiatives for people living with and affected by HIV. The model also attempts to trace the manner in which the response was shaped by and evolved from people's need rather than one that was guided by projects and programs. And finally, the model also seeks to highlight the importance of coordination and cooperation between individuals, families, communities, and services in order to achieve the optimum level of HIV care.
The continuum of care is not something new, but is intrinsic to any disease that is chronic in nature. HIV is a lifelong infection with no sight of a cure. People living with HIV have to deal with and cope with changing needs that are emotional, spiritual, physical, and medical, and additionally have to bear the burden of stigma and discrimination that they are often faced with.
To begin with, the module will focus on the programmatic commitments made in NACP 3. Later, we will examine the commitments made both in terms of resources allocated and the directions it has laid down on the continuum of care and support. We will then do a reality check and see to what extent the Bagalkot demonstration project conceived the continuum of care and support and what did they achieve in terms of integration from prevention to care and support.
The National AIDS Control Program Phase 3 emphasizes the need for integrated prevention, care, treatment and support program at the district level. For the first time since 1986, this program allocates a substantial proportion of budget towards not only prevention for the 99.7% of our population that need the prevention services, but also allocates a proportion of their budget for HIV care for that 0.3% who are estimated to have already been infected. The National AIDS Control Program Phase 3 clearly positions the integrated counseling and testing centers as not merely prevention services for general populations and high-risk groups, but also as the entry point to the HIV care. Prevention programs themselves have gone beyond the blood safety issues, the targeted interventions, and the STD clinics to also address rural populations, clearly recognizing that HIV has invaded into rural areas. So treatment, care and support interventions have now gone beyond the low-cost community-based care model, which only looked at terminal care and end-of-life care, to also address issues related to tuberculosis, which was the commonest cause of death, as well as antiretroviral therapy through which quality of life and the duration of life could be improved. Our approach has been to try and optimize the impact of the continuum of care in order to trace loss to follow-up at every level. We'd like to reduce the loss to follow-up between the time of diagnosis and their registration into the ART centers, from the ART centers to the networks of positive people and the community care centers to ensure the continuum of care. And ultimately, we would like to ensure that deaths and morbidity related to HIV are reduced.
Let us do a reality check. Let us take a look at the experience that we gained in Bagalkot. Let us explore to what extent these programmatic formulations were translated into practice on the ground.
In Bagalkot, we began with what we knew and what we could do. In communities, HIV was already prevalent, and people responded in the way that they knew best by isolating those who were affected by the disease into dark and lonely huts, through the doors of which food and water were pushed in.
One of the key responsibilities of the link worker was to reduce the unacceptable levels of stigma and discrimination. For instance, in village Kadlimatti, Macha, the link worker, tried to convince the family of Nagappa, who was living with HIV/AIDS, to take care of her 2 daughters. Her family was reluctant to take care of the children due to fear of being infected with HIV. One of the children was also HIV positive and died soon after. When Nagappa's younger brother came to the hospital to take the children, He saw Macha sharing food and taking care of the children without any hesitation. He shared this matter with his other family members. This helped Macha to remove the stigma amongst the family members and the villagers as well.
Our link workers, by just sharing a meal with them and their water, dispelled this myth that HIV was a contagious disease.
Having gained the confidence of the community and village elders, the link worker became the integral part of care and support services. This translated into many supportive practices.
Support group meetings brought people together, and they realized that they were not alone in this fight against HIV. The medical services, the nutritional supplementation, the opportunistic infection management, and the linkage to antiretroviral therapy helped to build this continuum of care over time.
It is clear that with every passing year since 2006, the service component expanded at the district level.
In the early phase, the only service component available in Bagalkot was Jeevan Jyoti. The link worker would do exhaustive counseling of the PLHIV and motivate them to attend the Jeevan Jyoti outreach clinics. By end of 2006, the service component expanded and we had a full-fledged ART center in Bagalkot. Even before the rollout of ART services in the district, there was a robust referral system established by the link worker. The link worker would identify the target population in the community, which are the people living with HIV, TB suspects, and most at risk population, and would appropriately refer them to service points, which may be PHCs, the district hospital, or the TB services. The comprehensive services provided at Jeevan Jyoti outreach clinics included psychosocial support, opportunistic infection management, nutritional support, and a whole lot of social entitlements. Before the ART center was rolled out at Bagalkot district, people would have to go to Hubli for ART. Once the ART center started in Bagalkot in 2006, the primary referral of the link worker was to the ART center for pre-ART registration and CD4 testing.